Welcome to AETCM, the emergency medicine channel. Today, we are going to discuss a case about one 66-year-old male who came to our ER with complaints of lower abdominal pain along with not able to pass urine for about 8 to 10 hours and also a history of dysuria. Shall we begin?
Yes.
So, on an initial 10-segment assessment, the patient was conscious oriented and the airway coming to the air was patent and no secretions were noted. In the breathing but the respiratory rate was 22 per minute with a saturation of 92% maintained on room air and circulation BP of 140 over 76 mmHg and pulse rate of 96 per minute. And on pain score he was complaining of pain of 8 by 10 and also he was complaining at that time itself, he was complaining of not able to pass urine. And right that point itself we asked to arrange catheter for urinary catheterization, and we went again with our assessment. Disability wise GCS was E4 V5 MFIS and pupil was 2.5 mm bilaterally equally reactive, and temperature wise at that point of time patient was afebrile. And sir, coming to the adjuncts, we took a VBG. VBG was showing 7.44 pH with creatinine of 0.9 and other lab VBG reports are within normal. No acid-base rearrangement was noted, and we took an ECG also. ECG was normal sinus rhythm with a heart rate of 90, and we asked for USG also. At that time, but USG later on we get the USG at a later point of time. We did for USG at that point.
But in ER, why do we do USG in this patient? Patient coming with lower abdominal pain, not passing urine. What do you look?
Blood.
You need to look for the bladder for documentation at least.
Yes.
If it is an obese patient, we won't be able to palpate for the urinary bladder, and all. In such patients, we can get a proof that the bladder is full with ultrasound.
So from our point of sight itself, we did the urinary bladder USG, which was showing a enlarged bladder, and by that point of time we got the catheterization, the catheter and everything got ready, and we tried to catheterize the bladder with 14 French catheter, and we could easily do the catheterization with the 14 French catheter, and there was adequate drainage of the urine, and as such there was no hematuria or pustules noted during the drainage of the urine. More than 1.5 to 2 liter of urine was drained initially itself, and we drained the whole bag at that time.
So immediately after inserting the urinary catheter, 1.5 liters of urine came out. Suppose if it is an elderly patient with BPH and you inserted Foley's catheter and this much urine came out, can we discharge this patient or should we observe that patient for some time?
We should observe the patient for some time. Ask patient. We had to rule out why the patient came to the ER with the complaints of urinary retention. So, if the patient is an elderly male, then high chance the patient might have a BPH, which can go on with which can produce the urinary retention, and we have to treat the
that
BPH.
Should be evaluated and treated. Other than that, immediately after placing Foley's, some patients, especially elderly patients, might be having post-obstructive diuresis. That means they might be passing more than the normal urine expected because of that relief of obstruction. So next hour they might be passing some 250 ml, next hour 250 ml. So what will happen is this patient will go for dehydration. So it's that phenomenon occurs. We need to hydrate that person. Okay.
And we went with the secondary survey. The history is that he was a 66-year-old male, known case of dyslipidemia, CVA, 4 years back, on medications of acospirin, clopidogrel and atorvastatin, came with complaints of
any other medications which can contribute to urine retention.
Medications like sympathomimetic agents, then antipsychotics, amphetamines, and then tricyclic antidepressants.
Then opioids can cause. Then drugs like oxybutynin, these drugs can cause
produce urinary retention. So right now the patient came with complaints of lower abdominal pain and sudden onset of not able to pass urine. He gave us the history of dysuria for the past 3 days associated with dribbling of urine and history of increased frequency of micturition. And he also gives a history of high grade fever with chills and rigor. He went to nearby hospital initially, and there in which he was found to have UTI and was treated with antibiotics, levofloxacin and nitrofurantoin, and was sent home at the OPD basis. He was sent home, and during the that stay, he developed acute retention of urine and came to our ER for further management. And other than that, no allergic history.
What may be the reason for the sudden retention here?
UTI causing infection causing and also he might have elderly male develop he can have prostatomegaly acid. When we did the USG abdomen, we got USG abdomen showed a prostatomegaly of size 27 cc.
27 cc is not that big. In a UTI who is having a moderate prostatomegaly like this, not moderate, even it is a minimal prostatomegaly, how do they develop complete retention?
Infection causes inflammation and prostatitis.
Spasm of the tract. That already there is a minimal obstruction. Sudden spasm produces complete obstruction. That's why whenever we treat urinary tract infection in elderly individual like this, we have to give antispasmodic drugs. That was a mistake done here. Only antibiotics will not relieve the symptoms in prostatomegaly. You have to give antispasmodic medicines like what normally we give cyclopam or whatever it is. That has to be given. Otherwise, patient will develop acute retention.
And after catheterization, patient pain got relieved. And on reevaluation, he was complaining of mild pain due to the catheter being kept there. Other than that, he was completely fine. And we did send for the routine blood investigation and urine investigation. The blood investigation showed raised CRP of 134 with the total counts of 18,800 and platelet count was within normal limits of 300, creatinine of 0.9. Sodium potassium was within normal limits, sodium of 134.3 and potassium of 4. We did send for a PSA. PSA came to be elevated, 12.46.
What it indicates?
During infection, PSA can be elevated.
Infection of the urinary tract includes prostatitis.
Prostate.
That time, anyway, PSA will be elevated. That doesn't mean that this patient is having actual elevation of PSA. PSA, what range you should be careful? Normal is what? Up to 5 to 7 is normal. More than 7, you have to always suspect BPH. More than 10 in a patient without urinary tract infection, you have to suspect malignancy. So this is during acute infection. Once you treat the infection, you have to follow up the patient. If the PSA is still persistently high, then you have to rule out malignancy.
Okay. Then later on, we got the urine analysis report also. Urine routine was showing 4 to 6 pus cells. Other than that, bacteria was negative and nitrite was negative. And we started with IV antibiotics for him, IV ceftriaxone, and
so on levofloxacin and
nitrofurantoin.
Should we stop it? Is it required to stop it? It is not indicated. You can continue the drug. There is no your actual urinary tract infection may not be there. It's only a prostatic enlargement which produces some inflammation in the tract. Okay. Even then, levofloxacin is a very good choice.
So,
what is the age of the patient?
66.
What may be only contraindication for levofloxacin in this patient?
Seizure
potential. Rarely, a elderly individual, this levofloxacin or quinolones can produce seizure, and it has got a high seizure potential. You should avoid in patients who is having seizure tendency.
So, after starting with the antibiotics and catheterization, patient got symptomatically better, and we did send for the blood and urine cultures. Urine culture came out to be negative, and later on when During the stay at hospital, patient was symptomatically better.
What do you think the reason for negative urinary culture?
Initially outside treated with antibiotics.
So how did we treat it?
That can be reasons.
Suppose if you place Foley's catheter, you attempt Foley's, and if it is failing, what will you do?
So if Foley's is failing, we can try with lower gauge French catheter or larger French catheter initially. If that also fail, at a point of time we can try with infant feeding tube also. And if you
to relieve the obstruction, we can try with the infant feeding
tube. If that is not possible, if urologists are not available, we can try with the needle to withdraw the urine at a small center PHC like that. Or else if
Where you put
from bladder, we'll lower bladder suprapubic will aspirate that with the needle. If urology associated center we have urology, we can go with suprapubic catheterization.
Here also one of the problem you should anticipate is the spasm. So you have to give antispasmodics and try the catheterization. So it will be easy. Otherwise it will be very difficult to put a catheter because of spasm, prostatitis, everything. So you give antispasmodic painkillers, then you try catheterization, it will be easy.
What our urologists will do is they will insert a long guide wire into the bladder, then they will be passing serial bar dilators, dilating and then inserting a Foley's. If that fails, then we will have to plan on SPC.
Yes. So in this condition we went for the SPC aspiration. We could catheterize the patient. We have to insert a SPC, like we'll have to initially we'll have to clean the area. We have to give adequate sedation, local anesthesia and sedation if needed. Followed by we'll have to insert a needle, and through the needle we'll have to go with a guide wire. And when we remove the needle, then we'll have to insert a dilator, and we have to dilate the area, and through which we'll insert the catheter. And once catheter is inserted, we can remove the guide wire, and that's how we do the suprapubic catheterization.
Suppose a patient is on urinary catheter, is coming with urine retention, what will you do?
So urinary retention in the catheter can be of multiple causes. There can be some clots or some obstruction can be in the urinary bladder. So we'll have to
obstruction in the catheter.
So we'll have to remove the obstruction. We'll have to give a bladder wash if possible. We'll try to remove the obstruction with the help of bladder wash.
Suppose if this patient is having a bladder malignancy, or if the patient is having a urinary, some patients, bedridden patients might be on long-term Foley's catheter, so they might be having a recurrent urinary infection and the urine will be very much clouded. So that sediments might be sedimenting onto the catheter, that might be causing the obstruction. If this patient is mobile, like a bladder carcinoma patient is mobile and there can be some clot, so that might be obstructing the catheter. So the opening of the catheter might be inside that clot. That's why the urine is not coming. So in such patients, under sterile precautions, if we try to push that the end of the Foley's catheter a little bit in, that tip which is inside the clot might be dislodged up, so that might not be inside the clot and it will be in that fluid liquid area, so the urine can be drained. So first, before doing the bladder wash itself, try to insert the Foley's little more inside. Sometimes that itself can relieve the retention. Then if that also fails, you can plan doing a bladder wash.
How do you treat that prostatic enlargement?
Prostate enlargement, we can give the tamsulosin fenestrate combination, and which will alpha agonist, which will help in reduction, relaxation, and which will help to pass urine.
One will help to relieve the spasm. One will help to reduce the size of the prostate. Okay, so that has to be started for this patient. So will you continue the antibiotic here?
Yeah, we have to continue the antibiotic as if the patient came with UTI infection. Patient can have the microorganism living in areas for a long period of time. So we have to continue the antibiotic nearly up to 4 weeks to remove out any organism left.
So what is complicated UTI?
Patients with UTI seen in comorbid patients.
Like stricture, stone, BPH, diabetes, all these things. There you have to continue the antibiotic for nearly 2 to 4 weeks. So that is very important. Okay.
Yes.
So what electrolyte imbalance you anticipate in this patient?
Potassium.
Is common electrolyte lost in urine in urinary tract infection.
Common electrolyte abnormality, which is
sodium. So any patient with UTI, you see the urine sodium, that will be very high. Urine sodium will be 50, 60. If the patient is not taking adequate oral feeds, he will develop definitely hyponatremia. This is one of the common cause for hyponatremia in elderly individuals. So you have to be always careful. This patient itself sodium is only 134. That is a lower range of the normal. So you have to be very careful. Even bladder wash itself can produce hyponatremia. Anything else?
Yes.
Thank you.
Okay.